Beautiful way to really illustrate some of the concepts that we've been talking about. And the opportunity we have now is to talk a little bit about, in a way that was sort of our introduction to what we can do to help kids who've been traumatized. And so what I'm going to do now is just spend a little bit of time talking with you about interventions for traumatized kids and in general, and I'm going to give you a little bit more information about trauma-focused cognitive behavioral therapy, the intervention that David used in particular, so that you, if you are interested, you can go and get more information. First of all, what I want to say is I'm going to try and, I'm trying to be broad because I know that we have a broad audience here of people who both do therapeutic work with kids as well as people who work with children in many different ways, whether it's educators or people who are sort of public health workers or people who maybe work in other frontline situations like shelters, for example. And there are different levels at which we can offer services to kids who are traumatized, obviously including both clinical and what I would call non-clinical interventions, i.e. interventions, things that can, strategies that can really help and don't require a mental health professional. So I'm going to cover both psychotherapy interventions, which of course trauma-focused CBT is one psychotherapy intervention, but also a couple of other ways to intervene with kids who've been traumatized. Acute crisis response, I'll talk a little bit about what can be done to identify and offer services to kids in the acute aftermath of a traumatic event. Preventive interventions, so what can we do for kids who you know have experienced something traumatic, but may not meet the criteria for a diagnosable disorder, at which point you would provide treatment. And those are preventive interventions. And I'll just spend a little bit of time on multi-system initiatives. So for those of you who are interested in sort of systems perspectives, those kinds of perspectives on serving kids who've been exposed to trauma. So some of you may be familiar with critical incident stress debriefing, and so I sort of find the best thing to do is to be really straightforward. Critical incident stress debriefing in particular, psychological debriefing in general, is the most well-known and widely disseminated approach for people who have been traumatized. The vast majority of people who CISD targets are adults. In fact, critical incident stress debriefing, or CISD, was originally developed for emergency responders. The idea was, and it actually came out of a military model, if you ask people to tell you what they've been through and give them an opportunity to talk about it, i.e. debrief, you will be able to address and deflect any potential traumatization or PTSD symptoms later. There's actually no evidence. There's actually a lot of controversy around this. This is an example of an intervention that's been widely disseminated with little or inconsistent evidence for its effectiveness. In fact, and I'm not going to spend a lot of time talking about adults because they're not our population today, but while there actually is evidence for the utility of debriefing, period, i.e. the opportunity for first responders to talk about what they did, so operational debriefing, the psychological debriefing is much more controversial. It's particularly problematic when we think about children. The idea that you would take groups of children and ask them to talk about different experiences, because of course each child has their own experience, in a group format, kind of let it all hang out approach, is problematic, because what we find sometimes is that you can have a contagion effect where kids who haven't thought about that, whose experience wasn't that kid's, now is that kid's because that kid's shared theirs. There's also some evidence that sort of intense debriefing interventions can actually interfere with natural recovery from trauma. And the fact is that most people do recover from traumatic events without clinical intervention. That's just fortunately, that's sort of a test to the resilience of the human spirit. So it may be harmful, and so I'm just going to be very clear about, and this is why we need evidence. We need to gather evidence about interventions. Psychological first aid is a different kind of intervention. There is some emerging evidence for its utility. It's used by the American Red Cross. It was developed by a group affiliated with University of California, Los Angeles, Bob Pinus's group, and it is a primarily psychoeducational tool. And the goal of psychological first aid, it's been used mainly with disasters, Hurricane Katrina, for example, to provide a lot of as much information to people as possible about what you can expect to think and feel, and about, be like after a traumatic incident. So there are guidelines for parents, and there are guidelines for teachers, and there are guidelines for working with children. And like I said, there is some emerging evidence for its utility. Then there are acute interventions. One example I'm going to talk to you about is the Child Development Policing Program. And these are interventions that partner first responders with mental health clinicians or social service workers to do a few things. One is to identify people who are kids who are exposed to traumatic events. The second was, we talked about the barriers to identification. And so, if you think about who are the people that see traumatized kids, well, police see a lot of traumatized kids. So if you really want to go right to the source and find, and be able to identify kids, then you're going to partner with the first people who are going to see them after a 911 call, for example. The second goal is triage, really, to be able to be a bridge to services so that if people do want services, they have the opportunity to get them. So often people are kind of left floundering. They have no idea what's out there. And then the third is to provide psychoeducation, again, similar to psychological first aid. What kinds of things do you expect to see? And that's kind of a normalization of responses, or it could be, a pamphlet telling parents, here's what you can expect to see in your children, and here's what to do if your kid's symptoms don't calm down after a month or so, which is, of course, the diagnostic threshold for PTSD. So I'm going to start by talking a little bit about what David talked about, which is trauma-focused cognitive behavioral therapy. David gave you a lovely example of TFCBT with this little boy who dealt with so much in his short life. Trauma-focused CBT was developed, as David mentioned, by Judy Cohen, Tony Manorino, and Esther Deblinger, who actually are in separate places, two in Pittsburgh and one in New Jersey, but developed similar models together and finally decided to collaborate. And there's really good evidence. Trauma-focused CBT is the child treatment with the most evidence for treating childhood trauma. I'm sorry, you can't see it very clearly here, but you should have it in black and white on your slide. I would strongly encourage any of you who are interested in TFCBT to go to the website, tfcbt.musc.edu. There, you can get 10 hours of free CE training on trauma-focused CBT. It's a really, it's a web-based training for clinicians on trauma-focused CBT. It's free, and at the end you can print out a certificate of attendance, which you can then submit for continuing education credits. And it has video vignettes, the kind of material that David was talking about. You see it in video vignettes that demonstrate different concepts and different components of the model. We are very interested in disseminating trauma-focused CBT. We do that here throughout the state. I mentioned earlier we have a collaboration with Minnesota's Department of Human Services, and we are currently midway through a learning collaborative with 45 clinicians in Minnesota in 8 agencies throughout the state who are learning trauma-focused CBT. And a prerequisite for any training in trauma-focused CBT is this 10 hours of training. And these are intervention models that require more than just a one day. Show up and then you're an expert in the field. And I think the field of interventions is really moving forward away from the models of come for a day and you're done to models like David described that include several days of training, followed by ongoing coaching. And in our learning collaborative, each clinician gets a 2-day workshop at the beginning, and then every other week, video ITV consultation with our consultant in Wisconsin in a group where cases are presented over a period of almost a year, followed by an advanced training. And so it's a really nice way to be able to also have peers it's a really good way of gathering practice-based evidence for how interventions work in practice. David covered the essential components, so I won't. But these are the sort of stages that David described in TFCBT. And I think you did such a nice job of talking about those. Let's go on to talk a little bit about preventive interventions for traumatized kids. And by the way, I'm not by any means saying that trauma-focused CBT is the only trauma treatment. If you are interested in trauma treatment in general, the last slide in your packet has resources. I would encourage you to go onto the National Child Traumatic Stress Network's homepage, nctsn.org, and there are lots of treatments listed there, as well as the standards by which they have been evaluated. So this is just trauma-focused CBT is one example. So evidence-based prevention. What is evidence-based prevention? These are programs that are not therapeutic, i.e. they don't have to be delivered by mental health professionals, although sometimes they may be, that have clear empirical evidence for their effectiveness in reducing or eliminating violence, for example. Or distress. And there are a couple of very well-known databases. There are more than 2, but these are the 2 most well-known in the US that screen and list these interventions. One is at SAMHSA, which is the same government entity that runs the National Child Traumatic Stress Network, and that's called NREP, the National Registry of Effective and Promising Programs, I'm not sure. But and the other one is at Colorado, the Center for the Study and Prevention of Violence, and they have the Blueprints programs where they also screen programs and really do a beautiful job of describing the program, describing what it targets, and what the standards were for judging how effective it was, and providing further information. And the kinds of programs that are included in the Blueprints or NREP databases, for example, in terms of, in the context of our population, are the nurse home visitation program, if any of you are familiar with David Old's program, which was originally designed to be a nurse home visiting program for high-risk moms in their second trimester of pregnancy. It provided 2 years of home visiting by nurses, and the data are absolutely remarkable for showing that over 20 years following the intervention, the outcomes for kids whose parents received the interventions are superior in all ways. The intervention was originally designed to reduce the incidence of maltreatment, exposure to violence. And not only did the intervention succeed in doing that, but if you think about all the cascade effects, if you think about providing support and the right kind of support and education, psychoeducation to a vulnerable, pregnant, young mom, the result is not just less maltreatment, but as a result, a healthier child who shows better outcomes in school, less truancy, fewer drugs in adolescence, fewer arrests, and things like that. So that's the power of prevention programs, where you recruit people who are not showing the problem, a disorder, but are at risk. So there you are. Nurse home visitation is the final one. I'm not going to spend time talking about all of them. You can get them online at the Blueprints, but these are the kinds of interventions that are included. Let's talk a little bit about parenting, my favorite topic. And I'm going to give you the example of the Oregon model of parent management training, which we call PMTO. And these are evidence-based practices in parenting, and anybody who has done parent-child interaction therapy or the incredible years or any kind of parent training, these models are based on the same theoretical principles developed from the theoretical work of Gerald Patterson. And basically, the rationale for parent training is that you offer practices, you support parents to develop or strengthen practices in providing solid, safe environments for their children to live in. And those safe environments, the parenting practices that are associated with safe environments include good, positive involvement with children, so parents who actually enjoy being with their children, effective discipline, good monitoring of children so the parents know what children are doing and are paying attention to them, good parent-child problem solving, so the ability to have effective communication between parents and children. So I know I'm missing one. Oh, and skill encouragement. So parents, as their children's best teachers, being able to effectively promote behaviors and skills, pro-social behaviors and skills in children. So my interest, parent training has been around for 40 years, but there's not been much written about parent training for traumatized families. And I'm particularly interested, my original sort of group that I worked with were families affected by domestic violence. And in that case, you know, in the whole parent training literature stemmed from an interest in understanding how families are affected by stress, called the family stress model. And the idea is that when families are under pressure, and it could be anything from socioeconomic stress to the stress of transitions, marital transitions like divorce, when families are stressed, the stress impacts the parent's ability to parent. And that's how the stress impacts the child. Primarily, stress impacts the child through its impact on parents' parenting. So for me, that was more than a powerful rationale to think about what happens in traumatized families, i.e. families where, for example, e.g., families where mothers have been abused, or families who've been through war, or other kinds of traumatic events. Most kids don't make it through mental health services, so why not provide something that parents can do to support their children? And parents are often the only available and critical resources for kids. So originally, this model, PMTO, was developed for all these kinds of problems, and in fact, it has been shown to be very effective at dealing with these problems. And many of the kids in the studies, any of you know multidimensional treatment foster care, that is a PMTO intervention or early intervention foster care, or a school-based intervention called LIFT or parenting through change. These are all variants on parent management PMTO. And I've sort of covered the effective parenting skills, and there are 5 of them. And what we are attempting to, let me just put that back up. And so what we are currently doing in our work right now is saying, okay, we know that these effective parenting practices work in highest standards of effectiveness. Studies time and time again have shown that if you train parents in these parenting practices, kids do better. How much better? This little graph that I'm showing you, it's one of my favorite little graphs, and it shows the probability of arrests since children's parents did or did not attend a 14-week parenting intervention called Parenting Through Change. And so this was a randomized trial where moms who were just divorced in Oregon were assigned either to a 14-week intervention called Parenting Through Change or not. No diagnosable disorders, just, a regular old, you've been through divorce. And the blue line shows the probability of arrest for the kids whose kids did not receive any intervention, kids whose moms went through the group, and the red line, did not go through the group, and the red line shows the kids whose moms did go through the group. And so what you see is, you see an increase overall because these kids were only 6 at the time that their moms attended the group, so they're not likely to be arrested, hopefully, before they're about 10. And of course, what you see in general across the population is an increase in arrests of children across adolescence, but you see how much more likely the kids whose moms did not go through the intervention did, or conversely, what a protective factor this intervention provided for the moms and ultimately the children who went through this group. So PMTO works, and what we have found is that it seems to act not just on kids acting out behaviors, but also on their distress. It helps kids, if you think about those same parenting practices, they really help provide a stable, secure environment for kids who've been traumatized. One could argue that they're even more critical then for kids who've been traumatized. And so what we've been doing is adapting PMTO for traumatized families. I don't really have time. I think I'm pretty close to being out of time. I've got like 5-7 minutes? Okay. So I'm just going to give you a quick example. We're adapting something called trauma-focused parent coaching, which is where what we do is we work with traumatized families. We now actually have worked with 4 groups of traumatized families in the metro area. The first group we did was moms who were in a battered women's shelter, where these are moms who'd been abused, they had very complex trauma histories, and had been exposed to both domestic violence, but also were homeless. They were in a shelter. And we worked with people in the community to implement this parenting through change intervention. And what's really interesting is that parent training doesn't explicitly focus on emotions. And of course, trauma, we've talked about this all the way through this morning, is all about emotions. It's about being overwhelmed emotionally that completely disrupts your regulation. And my feeling, from my hypothesis, to put it in a researchy way, is that what happens to parents who are traumatized is that they are totally overwhelmed emotionally, which really impairs their ability to manage their emotions when they're interacting with their kids. And when that is most clear is when they get into conflict or when they need their kids to do something. And it's much harder if you have any kind of a trauma trigger when you're interacting with your children. Think about how much harder it is to manage your own emotions. Think about how easy it is to get angered or triggered by your kids anyway, and add the trauma piece, and you have a much more complex, difficult challenge. And so what we focus on in our groups is what we call observing and managing emotions. And that is at the cornerstone, the ability to help moms observe and manage their emotions in a way that David talked about in trauma-focused CBT, where the child is taught to label feelings and to understand what feelings do in your body and to think about the thoughts associated with those feelings. We do that with moms as a way to help them manage and structure their interactions with their children. We have adapted this in the context of our center, which is a collaboration of all the entities here, and we have had very, very good findings. Like I said, our first try at this intervention was in a shelter. We tried it at Tubman Family Alliance, which is the largest DV agency in the state, in their Harriet Tubman shelter in Minneapolis. 2 incredible facilitators, both staff at Tubman, recruited 10 moms. And those 10 moms were residents in the shelters at the start of the intervention. And you guys know how transient a population it is. 14 weeks later, 9 of the 10 moms were still attending. And the average number of sessions that moms attended was 85%, which was really, we were just stunned, because everyone told us you could never provide services to such a high-risk, transient group of moms. And I had the privilege of being able to do a focus group with the moms after we were done, and they just talked about how what an incredible support the group was to them, and how it really taught them to kind of take back their household. Because as many of you who work with battered moms know, what's so undermined is they're so powerless and they're made so helpless by their abuser, and they sort of feel like they're now, the household's being run by their children often. And so they talked about how this has given them concrete tools to be able to provide their children with a more secure, safe environment. I'm just going to spend the last couple of minutes talking about collaborating across systems. This is really important in dealing with traumatized kids, because these kids enter into multiple systems. Some of them are in the child protection system, many of them are seen by cops, some of them are seen by hospital personnel, some by firefighters, and no one system can possibly help them alone. And so multidisciplinary partnerships, my experiences with first responders, and that web is just a link to an article about our child development policing program. But the goal is to increase awareness across multiple systems to be able to help traumatized kids. It shouldn't just be clinicians, educators, and shelter workers who know what to do to help traumatized kids. Police officers should know what to do when they enter a home. They should know about how to help 3-year-olds, the importance of a transitional object, things like that. And that's what multidisciplinary partnerships provide. And one of the things, for example, we spend a lot of time training Minneapolis police officers, and we tell them such simple things like, when you walk into a house with a 4-year-old who's just witnessed something terrible happen to his parent, what is the first thing that child sees? What is at his eye level? Your gun, your utility belt. If you get down on one knee to talk to that child in the eye so that he can see you, that will make a huge difference. And those are such simple things that we can really help if we cross disciplinary boundaries to help traumatized kids. I think I'm out of time, so I'm not going to spend much time talking about the CEVI, the Children Exposed to Violence initiative. But the main goal is to really show you that across the country, initiatives have been developed. And those include things like the Green Book or the Safe Start initiative that I consult with that bring multiple stakeholders together within and across communities to solve issues associated with children's exposure to violence. So I've given you a list of EBPs, not an exhaustive list, of evidence-based practices in trauma intervention, practices that really have been shown to be effective with traumatized kids. Other interventions are on the National Child Traumatic Stress Network website. These are just my favorites. And I've given you a list of web resources. And I'm really pleased to communicate. Anyone who's interested, you've got my email address on the front slide. And I think Joel's coming up, and I'll thank you for your time and your patience.